Glad you joined us again. We had a little bit of a break, and now we're back, and we are doing. We're going to continue on our falls and mobility, and really glad you could join us. So let me just get started, and hopefully more people will be joining in. So thanks for joining the Echo. Next slide, yeah, right here. So these are just a reminder that these are our partners and our collaborations. We have many, and everybody is just so excited and encouraged to provide more support for this long-term care community. Next slide. This is a reminder to everything needs to be confidential and HIPAA compliant. We want it to be a safe learning environment, and we want to encourage one another. And that Echo, and if we talk about cases, which I always encourage us to do, is we will remain HIPAA compliant, and that these case consultations do not create or otherwise establish provider-patient relationships between our Echo hub and you folks. These are just purely for education. Next slide. These are the the learning objectives for the entire Echo series. Next slide. And that in order to receive CMEs, you need to, after registration, complete an evaluation after the conclusion of this talk. And the link will be put into the chat box towards the end. Next slide. Okay, so this is our schedule, and right now we are in August, and we did falls assessment and evaluation last time, and today we're going to talk about maximizing mobility and the role of physical therapy. Next slide. This is our hub team. I'm the course director, Dr. Rita Bell Fernandez. She's one of our faculty here. Dr. Gail Rodriguez is a nurse facilitator. Dana Mitchell is here from Mountain Pacific, and Lori Henning is with HAH. So we're really glad to have our team. And next slide. And we have a special guest speaker today, and it will be Susie Neufeld from PT Works. I didn't see her. I hope she is on down the road here. So, but our speakers report that they have no conflicts of interest. Oh, there you go. Good to see you. No conflicts of interest with any ineligible companies as defined by the HCCME, but she is the owner of PT Works. Okay, so next. So without further ado, we're going to have Gail Rodriguez kick us off with the tip of the month. Thank you.
All right, so the tip of the month is serenity. And according to Webster's dictionary, it's a state of being calm. And according to the Cambridge English Dictionary, it's the quality of being calm. But serenity can incorporate a lot of things. For example, it could be giving thanks, practicing acceptance, being kind, getting enough sleep, keeping your environment clean. And it could also be calming your wandering mind. And a sense of calmness that can reduce emotional burdens and levels of burnout is a positive effect on well-being and our quality of life. So during our COVID-19 and all of our outbreaks, I don't know if we had any sense of well-being or serenity. However, thinking about how each person would express that would be different. So everyone would have different ways of expressing their serenity, well-being, sense of calmness, because it's much more than just a feeling. It's a goal. And in our nursing practice, we had holistic nursing, which incorporated this serenity and how do we treat our patients a certain way. And we tried to look at the whole person and try to find out things about them and then utilize it in our nursing care. And so you can be pretty creative in your interventions. And we could share in our chat, like, because everybody has a different way of expressing their serenity and what they do for their well-being. And I think that's important for every individual, not only nursing, but also all healthcare providers. So you can create your own list because it's all about you, and it's all about, so it's all about you. And I have a few examples. Some of the examples, sorry. I think my music just went on. And that was my music. But anyway, it's listen to dance music. It's watching funny videos. It's squeezing stress balls. It could be aromatherapy. It could be just taking a walk. Breathe deeply. Your yoga exercises, or visualizing in your mind, something very soothing. And it could be just chewing gum, drinking water, or even just writing something down. So that's pretty much what I wanted to share today for the tip of the month. So I believe we have
Next
Laurie.
slide. Wait, next slide. This is just the references. Did you want to say anything about it?
So the references that I looked at, in COVID-19, it began sometime at the end of 2019. And in 2020, the WHO, the health organization, World Health Organization, had created this illustration guide on what matters in times of stress. So I was pretty impressed that they already printed this out, and then we were already going into stress mode. So it's 132 pages, and that was an important reference for me, because it just talked about, you know, that people have different levels of stress and they have different things that happen and their life turns upside down. And it was pretty good in an illustration, because it's all like a cartoon like. And I thought that was important and interesting for people to see, that the World Health Organization had already created this prior to our big stress with COVID-19. And I just had some other references that were pretty old. They were in 2004, 2007, and then one that was in nursing practice that was in 1996. Although they used that in a lot of references in when they're writing about serenity, psychology, what matters, well-being. So they had it in a lot of places. And it was a great reference.
Great.
You're
Thanks.
welcome.
Okay, Laurie. Go
All
ahead.
right. Thank you. And thank you, Gail, for that information, because throughout COVID-19, you're right, wellness matters, and it's important that we take some time to take care of ourselves in that way. So, hi, everybody. It's nice to see you all today. I have just a couple of updates for you. So NHSN recently updated the therapeutics pathway, and if you're a user, you would have received that notification by email. So based on the feedback that they received, they included a new checkbox that says did not administer any therapeutics. And once that's selected, it'll auto-populate the rest of the pathway for you. So that made things a little bit easier for folks. And then the CDC's Operation Expanded Testing Program did just that recently. This program was previously targeted towards schools and shelters and correctional facilities, but it has now expanded to include free COVID-19 PCR testing for assisted living communities. And this is available just through the end of this year, through December 31st, 2022. So ALFs can receive up to a 4-week supply at a time. And there's also no cap on the number of tests that can be used in this program. So we wanted to make sure you had these resources in front of you in case that's helpful to you. For more information and to enroll, you can go to https://letsendthistogether.com. And then let's take a look at some of the information on our transmission rates and data. So for our community transmission rates that's designated by the CDC, we continue to fall into the high zone. I don't think that's a surprise to anybody. And just as a reminder, the CDC looks at new cases per 100,000 over the last 7 days, and also the percent of positive tests over the last 7 days in order to determine that rate of transmission. So right now, our nursing facilities are continuing to do what they've been doing for the last 2 to 3 months, and that's following the CMS requirement to test staff who are not up to date with their vaccinations at a rate of twice per week. And then the Hawaii Department of Health COVID-19 dashboard. I pulled this from them today. It was last updated on August 3rd. And this one shows the daily average cases and also the test positivity rate statewide and then by county. So we do seem to be trending in the right direction as far as this data shows. I also wanted to share some data from Laulima Data Alliance. So this is hospitalization data, and it shows COVID census statewide over a 7-day period. So this particular data set is from July 29th through August 4th. And you can see the daily stats here as well as the 7-day rolling average. So according to this, we saw an average of 24 new COVID admissions statewide. We had 8 COVID positive patients in ICU beds and an average of 136 COVID positive patients in hospital beds over that week, which was a 1.2% increase from the previous week. And then these next 3 slides show those trends over the duration of the pandemic for the state of Hawaii. So using those same metrics, this graph is reflecting the data. It's actually data through August 8th, so yesterday. This is very up to date. And this one depicts the total confirmed COVID positive patients in hospital beds in our state. And again, you can see overall it's trending downward. Our ICU bed usage rate has bounced up and down a little bit, but overall it is also headed down. And then the same with the total new COVID admissions per day. You can see again, we've been up and down, but again, we just seem to be headed downward here. This is kind of over a 2-week look back as we can see what's happening. So this slide shows the rate of confirmed infections by state, so nationally, and it's for the week of July 28th through August 3rd, 2022. So Hawaii fell pretty much in the middle. And the last time we met, Hawaii ranked as second in the nation on this metric. So it's good to see that we are dropping back down. For the total confirmed infections by state per 100,000 individuals, this is for the entirety of the pandemic from March 7th, 2020 through August 3rd, 2022. And you can see Hawaii has the second lowest infection rate in the nation. And now, you know, that kind of has been held by a couple other states, including Vermont, but now Maryland holds the position of having the least number of confirmed infections. And then this slide shows where Hawaii ranked, again, for the week of July 28th through August 3rd, related to COVID-19 death rate per 100,000 individuals. And as we look at our ranking for the entire duration of the pandemic, Hawaii has the second lowest death rate in the nation, and it's right there after Vermont. Okay, Dr. Nguyen, that's all the information I have for today. I will hand it back to you.
Thank you. Okay, and now we'd like to move on to Dana Mitchell over with Mountain Pacific, and she'll talk us a little bit more through falls, because we are just following up on last month's session on what to do at falls, and then now talking about falls prevention programs.
Yeah, thanks. go ahead and hit the next slide. So just briefly, I'm sure everybody here is very familiar with our quality measure reported through the, what's it called now? Healthcare Care Compare. We've got our long-stay measures of the percent of residents experiencing one or more falls with major injury. That's very straightforward. It's just folks in the look back period who have had a fall with a major injury. And then next slide is just the prevalence of falls, QM. So percentage who had a fall during their episode of care. Those are some pretty straightforward QMs, thankfully. Next slide. So I went to a practitioner, educator who I respect a lot. And she wrote a white paper on a falls prevention program. Her name is Patricia Quigley. I believe she most recently works with the VA in Florida, but she has developed a really great sustained program of research in fall prevention and management. She works with both hospitals and long-term care. This particular presentation or program that she had really kind of was worded for hospitals, but it's certainly applicable in long-term care, and especially with my experience in the SNFs, I just really appreciate the work that she's done. And you know, one of the things she says is that it's just conclusive that fall risks are multifactorial. That's not shocking to any of us, and that effective fall prevention programs are interdisciplinary. Also not surprising to us, although sometimes difficult to implement and sustain. She says, however, most, or I would say many healthcare organizations still rely on universal nurse-led methods that are ineffective and create a false sense of safety. Next slide. So we're going to talk a little bit about what she identifies as some obstacles and some steps that we can make to enhance and improve our fall prevention programs. So one of the obstacles is really our limited clinical education. We typically tend to be focused on your fall risk assessments at admission. You might give them a risk score or risk category, and then maybe a prescribed set of interventions. That really doesn't get at your individual's risk. Limited IDT involvement. A lot of times it can be left up to nursing to manage all of those steps, but if you don't have all of the people looking at the different pieces of the puzzle, you're not going to be able to implement effective interventions. Having a lack of population-specific methodologies. For us, I think we have this more. Most of our folks tend to be elderly, frail, and post-surgical, which are the highest risks for bad outcomes with falls. And they tend to have specific needs compared to the rest of the population. And a universal approach to post-fall care planning. Sometimes we're not real great at identifying and responding to the root cause of a fall. I think we're very good at least in my experience, have been very good at identifying contributing factors, but not necessarily getting to your root cause and addressing that. And you've got to have that whole IDT there in order to get your full picture. Next slide. So the 6 key steps that she outlines are your comprehensive assessment, your population-based approach, safe toileting has its own section, mobility, individualized post-fall care planning, and increasing your resident engagement. So those are some suggested areas of focus for your nursing and your IDT knowledge and skills building when it comes to falls prevention. Next slide. So I was looking through these, and I think this slide and the next slide are remnants from a presentation I did previously that don't necessarily apply to this one. I didn't do my proofing before I pulled this up. So we'll go ahead and skip this slide and the next slide. And my apologies for that one. There we go. So let's talk really about a comprehensive assessment. Dr. Quigley says that whenever possible, staff should work collectively to develop care plans that connect your assessment findings to specific interventions needed to modify or eliminate your risk factors present. So you've got to focus on your underlying causes of your risk factors that you've identified. You should include those population-specific risks, such as the age of your resident, what are their specific diagnoses and their functional abilities. Connect your interventions to those findings, and you must continually be reassessing in order to catch new or modified risk factors. Next slide. So let's talk a little bit about your population-based risk factors. Again, don't use universal risk assessments. Look at your population-based approach. And she calls this a ABC, ABC, I think it's supposed to be S actually. Age, bones, their coagulation status, and post-surgical status. So the folks who are age 85 and older are at an extremely high risk for bad outcomes with a fall. Their state of their bones, if they are at risk or they have a history of a fracture for breaking bones when they fall. What's their coagulation risk? And then are they post-surgical? So there's a study done in 2018 that did a look back from 2007 to 2016 that determined that fall-related deaths in adults over 65 increased by 31% from 2007 to 2016. And the deaths from falls among persons age 65 and older, golly, excuse me, I went to the dentist today, so I'm having a little trouble enunciating, have also increased dramatically. Next slide. Okay, so one of the next steps is emphasizing safe toileting. So we all experience, I think, a large number of bathroom falls. They're related to navigating the physical environment, how they get on and off the toilet, actual act of using the toilet, and then during personal hygiene. It's also, and I'm sure we're all, been in this situation, difficult to navigate that cramped space when you've got a resident and a staff attempting to assist them, and that creates its own risk. She's pretty emphatic that grab bars can be problematic. It depends on where they're positioned. So if they're often positioned away from a resident's body, which then limits their ability to use their proper biomechanics in order to transfer. And of course, they stick out and can be a source of injury if they're hit during a fall. Next slide. So engaging residents and families, you want to involve them in your prevention planning. Your outcomes and your satisfaction are always going to improve when the residents and families are fully engaged and involved in their care. Want to make sure your staff have the skills that they need to educate and engage the residents. She recommends using a teach back approach to improve your resident family retention of education, which will help you identify what they retain, what they understand as far as safety protocols that you're telling them or teaching them how to mitigate risk, and what they might need more help with. And this was interesting to me. Ask the resident, what is their perceptions of fall prevention and falls? Sometimes their perceptions can get in their own way. For example, they may not understand how important fall prevention is and how devastating a fall could be. They might also blame themselves for their falling or for their medical conditions. They might just simply be one who's going to engage in your risky behaviors that you need to attempt to mitigate, or they might be reluctant to impose on your busy staff. They may say, I don't want to call anybody for help because I know how busy you all are. We hear that all the time. And being aware of those perceptions can help you identify and address them. Next slide. So mobility, which I know Dr. Nguyen is going to get into. We all know limiting mobility leads to their decline. It can lead to confusion, pressure injuries, infections, a whole list of things that I think, interestingly, we have really come to appreciate coming out of the pandemic when we've had to isolate people. And then we all know the benefits of maintaining mobility. So we want to make sure that we're training on mobility assistance. Next slide. So we're going to talk about post-fall care plans and conducting a post-fall huddle. So I would like, if folks are willing, to type in the chat box if you use a post-fall huddle and how successful you think it is, and maybe what makes it successful if you're utilizing one. So really the entire IDT should be available for post-fall huddles, which is really challenging. in the nursing home setting. I know I worked and worked and worked to try to get folks to pull that whole team together, but your therapists are busy, your nurses are busy, your pharmacists may not be there. And so I understand how difficult it is to get those folks together. So this, as best as we can, we need to try to bring all those brains to the table. First, you want to look at what type of fall was it? Is this an accidental fall that's going to have a whole different intervention than, say, an anticipated physiological fall, which is something that you could perhaps anticipate based on their conditions, their diagnoses, their status. For example, a stroke, and they have a one-sided weakness or the other. That might be anticipated physiological if you're aware of their orthostatic changes. Or an unanticipated physiologic fall, something maybe that's cropped up that hadn't been assessed before. And those are all going to have should have different interventions based on what that root cause was. Look around the environment. What's in there that may have contributed? Do you have equipment in the way, things to trip over? I mean, we all know all these things. Is the floor wet? Bed too high or too low, I think, is one that is challenging to get our care staff to understand that based on someone's height, weight, abilities, the bed may need to be in a different position. What's the lighting like in that room? I mean, all those things I think that we're aware we need to take a look at. And then based on that, these are some resources for you that I found. One is this paper from Dr. Quigley. We have an AHRQ falls management program. The Interact, of course, has a falls management program manual and lots of great safety and communication tools. And Mountain Pacific has got a quality measure tip sheet on our website, which really is about coding properly and things to look at if you're maybe missing on a measure. And I believe that's it. Are there any questions or comments, or anybody who'd like to share your experience with a post-fall huddle? I had a conversation this morning. I was going to mention that I think we've got at least one or two folks here from Navis, who I think many of you work with there in Hawaii, who have done a lot of work around falls. And we were having a conversation today about root cause analysis tools and the challenges sometimes in getting everybody to understand the point and the use of a tool. For example, I used a 5 Whys post-fall huddle tool that you could tell when the education hadn't reached out to the people who had responded immediately to the huddle, because sometimes I would have one answer in each of the 5 Whys. It would be the same answer. Why did this happen? Why did that happen? Well, because the same thing, it was written all the way down. So I knew I had to improve my education. But does anybody else have any other tips or things that have worked well for you? All right, well, we will move on. Feel free to type it in the chat if you've got anything you'd like to share that you think your colleagues would find useful.
Great, thank you. And I just wanted to just say hi to Darren. I know he's with the Navis here, and I know some of you have worked with him as he's created these nursing home collaboratives, working with HMSA. But anyway, we will be working together to provide more support for the long-term care community going forward. And so I just wanted to say hi and welcome. You want to wave hi, Darren, and then we can move on.
Hi, everyone. Good to see some of you. I know I've worked with you guys before, but yeah, now with Navis post-acute care collaborative network. And I know that there's a lot of us out there. I also have Kellyanne and Sam, who are part of the post collaborative. And I know that we're all working on these quality improvement initiatives with the facilities, all together. And so like, how can we collaborate? Because all of us have the same initiatives for facilities, and we all know how much they have going on internally, and like the struggle is real. Like we want to do fall prevention and get the IDT involved and go through all of this, post huddles, but internally, day to day, we do know the struggles that go on just to keep the building staffed and try and pull everybody together. So how can we just all work together and come up with, best solutions all the way around. So really appreciate Ida reaching out and everything that everybody's doing to provide the best quality of care for our residents and help the facilities out. So thank you, Dana, Ida, Gail, good to see you. Laurie, good to see you.
Awesome. All right, now everybody here is doing great work. Okay, and now without further ado, Susie Neufeld from PT Works. Thanks for sharing. You have to unmute.
Are we good? Can you
Yep.
hear me?
Mm.
Hi. So I see that you have loaded an earlier presentation. I actually have another, I tweaked it. So can I just do a screen sharing? All right. Okay. Can you guys hear me? Everyone can hear me? Okay. My apologies. I am not good at doing this whole Zoom thing. So all through the pandemic, we were still able to go into all of the facilities, see patients, and I'm not good with looking at a computer screen. So just forgive me if I make mistakes. But anyways, my name is Susie, and I am the owner of PT Works. And so basically I staff at about 18 different assisted living homes and care homes throughout the island. I staff for physical therapy, occupational therapy, and speech therapy. And I've been doing this for about, I've been strictly a geriatric physical therapist for about the last 15 years, and have had my company for about 13 years. So I've seen a lot, I've seen a lot of geriatric clients over my time, and have seen falls. And so anyways, so yeah, I wanted to just talk about what is physical therapy, and how do we maximize and maintain function. So first of all, physical therapists, we address mobility and ADL deficits through various techniques. That it's through strength training, neuromuscular reeducation, balance, fall prevention. That's a big one in geriatrics. Range of motion, flexibility activities. We utilize pain management techniques, to get that person up and moving and become mobile without pain. We do home safety assessments, and we develop home exercise programs. So due to insurance restrictions, physical therapists, we do have a limited time with patients. And, a key treatment approach is to provide, meaningful mobility tasks and exercises that can be carried out by the patient or the caregiver, once that patient has been discharged. So that is an important treatment approach. Our goals of geriatric physical therapy is to keep the client active, prevent deconditioning, slow or decrease muscle atrophy, prevent falls, maintain the highest functional level as possible. And then what I really think is very important too is create a partnership, with the caregivers and the patients. So, we are a team working for the same goal, and that is to keep the client active, mobile, and to prevent falls. So our job, and my job as a physical therapist, is to help create that partnership and educate everyone involved in the care of the client. And so what we're going to do, we do this by educating caregivers, on that patient's current functional level, and by creating, home exercise programs that are realistic and that can be carried out, by the patient or the caregivers. And caregivers, I'm meaning the nursing home staff, ALF staff, care home staffs. As a physical therapist, I can get that patient up, moving, and have them improve functionally. But if nothing gets carried over, once I discharge that patient, they can quickly decline and go back to where they were when I first started them. And this is why I believe that, that partnership and that education is such an important goal, of geriatric physical therapy. So I'm sure you guys have all heard the statement, if you don't move it, you lose it. And this is, so true for the elderly. So let's just look at that scientific evidence of the benefits of exercise in older adults. So, based on this slide, there's strong evidence that compared to less active men and women, older adults who are physically active, they have lower rate of medical issues, healthier body mass, enhanced bone health, a higher functional level, and just better cognitive functioning. So you can see, just by adopting, an exercise program, keeping someone mobile, you are going to have those positive benefits of exercise. And exercise really becomes more important even as we age. But also, I love this slide. This really shows like how important exercise is. We've always had like that recommended dosage of exercises, but far too long we've neglected that dosage. And I'm going to actually discuss that in a few minutes. What is the appropriate exercise for elderly adults? But I love this slide. Exercise is the miracle cure. So if exercise were a pill, it would be one of the most cost-effective drugs ever invented. This is why we need to make exercise really part of the daily plan of care for our patients. When residents are mobile, they are healthier and they are happier. And, again, when you have a healthier resident, they are on less medications, hopefully. And we all know, like, the more medications that an elderly person is on, the higher the risk of falls. So let's look at the effects of immobility in the elderly. Again, I love the statement, if you don't move it, you lose it. Because what happens? What happens when an elderly person becomes immobile? There's muscle atrophy, deconditioning, there's increased pain because they're just not moving. So what happens is that their joints become stiff. They start getting contractures, and they don't want to move because it's painful. Ultimately, that leads to decreased function. Decreased function leads to immobility, and it leads to fall risk. And so falling, as we all know, can have like tremendous physical, but also psychological effects, on seniors. Falling can lead to head injuries, it can lead to fractures and death. But even if a senior recovers from a fall, they can be left with that fear of falling again. And fear of falling leads to social isolation, inactivity, decreased functional independence, and depression. Also that chance, once a person has fallen, an elderly person has fallen, the chance of them falling again increases. And I have to say, like, in my years of working as, being a physical therapist, working with the elderly, I really do see the psychological effects of falling. They're so fearful that they don't want to leave their room anymore. They're embarrassed. So, it really is important that we keep those we keep those residents like, mobile for as long as possible. Okay, so we've talked about, what a physical therapist, our treatment approaches, what our goals are of physical therapy. We've talked about like the consequences of falls. And we've also talked about, just the benefit of exercises. So what I want to do is talk about like that recommended exercise dosage that is needed to keep our residents active and healthy. Okay, so the CDC, NIH, and American Medical Association, their recommendations for exercise in older adults should be 150 minutes of moderate intensity aerobic activity throughout the week. And when you look at that number, that seems like very overwhelming. And so I always like to break it down. It's 30 minutes a day, 5 times a week. And also, if 30 minutes is too much for a resident, it's also okay to break it up in like 10-minute spurts of exercise. So that's okay as well. And we're going to talk about, what we can do, for that, the different exercises that we can do for moderate intensity aerobic exercises. So it's that 30 minutes a day, 5 times a week. And then also on top of that is muscle strengthening activities 2 or more days a week. And so like my job as a physical therapist is really to develop like realistic, like exercise and mobility programs that can be carried out by the patient or the caregivers. And this really is a general guideline that I always follow. In fact, in the assisted living facilities and care homes that I work, we're working under their outpatient benefits. So we really can't see a patient every single day like someone would in an SNF or a therapist would do in an SNF. We just have different insurance requirements. But I make sure that I schedule and that my therapists schedule, the patients at least two or more times a week. Just because I want that patient to be able to get that benefit of a muscle strengthening program, of that fall prevention program. To me, 1 time a week, it doesn't do anything. Unless a patient is very motivated and they can carry out their own program. So I know that some of you are probably thinking, well, this is just not realistic for my facilities, but it really can be. Aerobic activity can be as simple like as a walking program. And this is what I see. This is what I recommend a lot. Once a patient is being discharged, is like that is, I tell the staff, like, just walk them. Or I tell the patient, I'm like, you gotta walk. You need to walk. It's like, if you're not going to do anything, please walk. The benefits of a walking program in older adults is, there's an increased likelihood of staying independent, improved aerobic capacity, improved like physical functioning, improvement of the ADLs, and then again, a decreased risk of falls. So how do we walk with the patient? How do we adopt a walking program? And again, that's my job. That's my job as a physical therapist, is when I have that patient, I'm looking to see what can they do? What can they realistically do? And what can the staff realistically do with them? How much assist do they need? How far can they go? When I'm setting these goals, I want to find out, what motivates the resident. Like if I say, okay, well, I want you to walk down the hallway 3 times a day, 150 feet. Well, if there's just nothing, like if they're not motivated, then it's not going to work. So I like to teach like meaningful walking. So, I will break it down. I say, okay, so first of all I want you to do is walk to the shower or to the bathroom. Then walk from the bedroom to every meal. Walk from the car to your doctor's appointment. So you break it down, you start small, and then you can work up. And then again, it's what is meaningful for that patient. How are they actually going to, what motivates them, to walk? In care homes, what I will teach is, take the residents out, go out to the mail, go take them to longs. Everyone loves going, they all love to go to longs. Take them on outings. And again, what we will also do is like, we will tell the residents, we'll tell the family members or the staff, we'll say like, hey, you know what, if you want to be able to do this, if you want to be able to go to longs, okay, you need to start walking, from your bedroom to the dining room for every meal. So it's just really setting those like little mini goals to reach like a higher goal of a resident. I love walking group programs, or group walking programs at a day health center that I'm part of. They have the Kaholo program, and every day after lunch, the residents that are ambulatory, the staff and the residents get up and walk. And they walk around. It's probably about 200 feet or so. It's like this big circle around this assisted living center. And I love it. And, they make it's part of that daily program, and it becomes a habit. And they do it. So there are a lot of benefits, of doing a group walking program. So cues for safe and effective walking is look up, take those big steps, open up your feet. I mean, that's what we say all the time as we're cueing and we're facilitating walking. Those are our three big, those are our three big cues that we always, work with. We always teach the family members or the caregivers or even the patient, that we cue them, just to have a more efficient walking pattern. Also keeping that walker in front of the resident. We just don't want to make sure that walker gets too far out in front of them. Again, what happens if it gets too far out in front of them, their head goes down, they start taking littler steps because they're out of their base of support. So we always want to teach like just bringing that walker back into like their base of support. And then just a correct walker height rule of thumb is like you want that walker to be positioned to where the elbow is about at 10 degrees of elbow flexion. So just a little bit. You don't want to have like too much bend in the elbows. So I always encourage our residents to go to group exercise class as well. I love group exercise class, and sometimes that is the resident or the caregivers, they just can't do like that. They're just not motivated to do like an individual by themselves exercise. So I just love group exercises. And a lot of times we make that part of their treatment plan is like attend group exercise, like 5 times a week. I love this video. So I had to show this video, or I have to share it.
All right, here we go. It's 1, 2, 1, 2, 3. You get your heart rate up, you get hot. 1, 2, 1, 2, 3. You don't have to know how to drum. This has nothing to do with drumming skills. It has nothing to do with knowing however Ringo Starr beats his drums. It has nothing to do with that. Nothing. 4, 3. Reach. Things don't work like they did when we were in our 20s or 30s or 40s. 3, 2, reach. The only thing I can say is if you don't use it, you are going to lose the ability. Oh, don't we sound professional? Keep it center. 4, 3, 2, here we go. Keeping our upper body strong to push us up out of chairs to help us lift things. I mean, you know, it's part of staying alive.
Fun. I mean, you're just laugh. You know, the music is really important. She picks out great music.
3, 2, again.
I would recommend it to anybody.
I find that it's much more strenuous than it looks.
2 and rest.
A lot of fun, for one thing. I have to have fun when I exercises or I don't do it. And that's the main thing for me, is having a good time.
It's down and up, down, up, down, up, down, up. All right.
Oopsie. I love the drumming. And I think it's so appropriate for Hawaii as well. And, you know, with the taiko drums and I'm seeing a lot of this drumming class in the care homes that I'm at and the assisted living homes that I'm at. So again, we want to make just what those seniors said. You want it to be fun, you know, like you want this group exercise to be fun. And again, that's going to get those residents motivated and want to come to, you know, to exercise class. And I don't know why right now I am stuck. This is stuck and it's not moving. Okay. Okay, let me try this way. No. Okay, there. Good. Okay. So like I had talked about it before, so you know, seniors should be doing that 150 minutes of moderate intensity aerobic exercise, and also adding that the strength exercises at least 2 days a week. And strength specific exercises could be the chair yoga, the seated tai chi, lifting the weights, working with resistive bands, or just doing exercises, you know, that uses their own body weights. And again, this is where that group exercise classes in these assisted living homes and care homes and nursing homes are just so important to have. So what I see, you know, and what just really just makes me very angry when I see this, you know, video exercises, they're fine, but, you know, don't make sure that, you know, that the staff, you know, if you guys are if you're going to do a video exercise, number one, make sure it's appropriate. It's an appropriate level, you know, for the residents that you have, and make sure that the staff is there and that they're participating. What I see and just what makes my blood boil is when I just see you know, I go into like a locked memory care unit and there is a fast-paced exercise program that is on, or exercise video. You see the caregivers just kind of sitting there, and also the residents sitting there, you know, because it's just not appropriate for them. You know, it should, if you are going to do the group exercises with a video, again, make sure that it's slow, you know, make sure that, and also make sure the music is related, you know, is that the seniors can actually relate to that music. It's not appropriate to have like rap music or today's music, you know, on, you know, make sure that it's appropriate for the generation that you're working with, because again, we want to be able to motivate those residents to participate in exercise classes. I don't know, Dr. Nguyen, were you guys able to get a list of my, okay, of these exercises. Okay, so basically, I came up with what I think are just key exercises that should just, it should be done with in any kind of group exercise class, or, exercises that, an individual resident can do. If I had to pick one though, if somebody said, okay, Susie, this patient can only do one exercise, I would do sit to stand. Sit to stand, like repetitive sit to stand, is so important. It's going to work on all of those muscles that are needed, to perform transfers, also to perform walkings, to perform ambulation skills. I like to do the mini squats. We like to teach the mini squats, calf raises, the sideways leg lift. That's gonna work on those glute muscles needed for stability when we're standing. Wall press ups, or press ups against like a countertop, and bicep curls. And again, the recommendations for strength exercise, it should be at least 2 days a week. And most of the time when I'm setting my reps, and my sets and my reps, I usually will do about 10 to 15, depending on, what the resident can tolerate, and 2 sets. Balance is a really important component, of a just a healthy, solid group exercise class, and also, for an individual patient as well. I mean, obviously, it's a really important part of fall prevention. And, balance exercises should be part of that resident's exercise routine, especially if they've had falls. Some of the different balance exercises that I like to give to the residents, and that I think could also be part of a group exercise program, is just like a sidestep. So where you just sidestep together. And again, the goal of these balance exercises is really to challenge that proprioceptive, vestibular, and visual system. And those are everything that you need, to maintain your balance. I like doing like the grapevines, but it's really just standing in place, cross one leg over the other, cross the other leg over the other, holding on to that chair or counter. We also teach like a heel toe. Heel toe walking is very advanced. It's a hard one to do, but what we will have our patients do is like stand at a countertop or a chair and just try to put one foot in front of the other. A lot of times they can't. That's because it is a much higher level balance activity, but we'll have them do a staggered stance, and then hold that for about 15 seconds or so. And again, holding on to a countertop or a solid surface. I also just like standing one leg balance, and then holding that balance, for that 10 to 15 seconds. And again, all this can be done in a group exercise class, but you just have to make sure that you have like a solid chair, or a front row walker for support. And flexibility. You can't, we also, like as a physical therapist, I cannot not touch a patient. Like it's so important that we do look at flexibility. Because what happens is as we age and we get older, everything starts coming forward. Now, we're never going to, I'm also realistic. We're not going to get that person like fully upright, but what we want to be able to have them have flexibility and motion through that available range, so they can lift their head up a little higher to see, where they're walking. So, flexibility and stretching, again, is a really important part of those, like a group exercise program, or, an individual program that we, teach the an individual caregiver or a patient. So some of the really good stretches, and very basic stretches are like the neck stretches, doing the neck stretches, looking up, trunk stretches. You can do a seated rotation stretch, and all that is in here in the handout that I gave you. Supine, we've got hip flexibility stretches, hamstring stretches, chest stretches, opening up those pecs, working on the range of motion of the arms. So there's all kinds of stretches that can be done. And, it really does feel good too. I'm sure, right. I'm sure you guys, as you're sitting here now for an hour, it's like your body is starting to stiffen up, get a little sore. And if you did just a few minutes of exercise, of stretches, that it's enough just to increase that blood circulation and just wake yourself up to where you're like, okay, I can do this. Same thing with an elderly person. If you just allow them to sit there all day long, okay, they're going to stiffen up. They're going to be in pain. They're just going to be much harder to work with, probably in bad moods too. So it is important to have just a really nice combination, exercise program for your residents. This is including some aerobic, moderate intensity aerobic exercise, some strength exercise, the addition of balance and flexibility. And like I said in the previous slides, it is okay to do aerobic activity in bouts of 10 minutes. And you can modify the standing exercises, or the standing exercises for balance and strength, if the resident is unsafe. And, if you do have the physical therapist at your facilities, talk to them. They know how to modify, they know how to work with the residents and modify a program so it would fit that individual resident. They would be so excited if you talk to them about that. And then again, it's best to be proactive rather than reactive. We don't want to wait for falls to happen. We want to be very proactive, and one of the ways that we do that is keeping people mobile. And you keep people mobile by keeping them motivated to do exercises, to keep walking. All right, and that's it. Thank you for your participation. I see a lot of us have the same stock slides.
Thank you so much. Unfortunately, we're a little bit over time for Q&A, but I want to tell you, I've been inspired, and I hope everybody has been too. I looked at those handouts. They're fantastic. We should all implement them in our facilities. And I, for one, I prescribe sit-to-stands to everybody I can at my facility.
Yes.
So that's fantastic. Just so you know, we have time for the evaluation part. There's a evaluation for CMEs. Make sure you click on that and do it right away, so you make sure you get your credits. And that over the next few months, we will be looking at some of your anonymous MDS data for short stay and long stay residents with falls or major injury, as well as looking at ADL performance, functional ability, mobility, bladder and bowel incontinence, and things like that as kind of proxies for having more mobility programs and reduced risk of falls to demonstrate effectiveness. So I'm hoping that the combination of the stuff you've done with a novice on falls prevention, understanding how to evaluate and, do root cause analysis for specific care planning, and, being able to routinize all of this strengthening and stretching and everything is going to really take our residents up to the next level. They'll be much happier and much more mobile. So thank you, everyone. Okay, I think Michaela just posted the link to the resources page, and it's yeah. So take a look a little bit later. I think it'll be posted later.